Hi and welcome back to another video of Medic Notes. This video will be on bladder cancer. Bladder cancer is the second most common urological cancer, following the cancer in the kidneys. 80% of the cases are diagnosed in older people, which are more than 60 years old. And the most common type is the transitional cell carcinoma, where there are also other types, such as adenocarcinoma or squamous cell carcinoma in the bladder. These are the factors that increase the risk of one having bladder cancer. It can be divided into occupational risk factors or non-occupational risk factors. So the first 2 points are the occupational risk factors, such as exposure to aromatic amines, such as those working in factories that do printing, textile factory, rubber, or such as plastic factories. And also exposure to industrial chemicals, such as B-naphthylamine, aniline containing dyes, or those who work as synthetic rubber workers. These are the people who are at a higher risk of bladder cancer. Other non-occupational risk factors include smoking, which increase the risk 2 to 3 times compared to those who do not smoke. Chronic analgesia abuse, especially phenacetin. Chronic parasitic infection due to schistosoma hematobium, which is a parasite that causes squamous metaplasia in the bladder. Chemotherapy due to exposure to cyclophosphamide, which will induce hemorrhagic cystitis, and chronic cystitis may cause bladder cancer. Chronic cystitis can also be due to pelvic radiation. And other risk factors include males are more common than females, and also age more than 50 years old. Patients who have bladder cancer might present as such, where the most common presenting symptom is persistent painless hematuria. So it is painless blood in the urine noted, and it is the most common presenting symptom, which consists out of 90% out of all the cases. And their urine is typically having gross hematuria, where we can see blood in the urine. It is painless, intermittent hematuria, and occurring throughout the urinary stream. Other features include lower urinary tract symptoms, LUTS, which can be divided into irritative symptoms and obstructive symptoms. Irritative symptoms include frequency, where the patient frequently goes to the toilet compared to before. Dysuria, where there is pain during urination. And urgency is they have a sudden urge that they need to go to the toilet, and sometimes they cannot hold their urine before reaching the toilet. Nocturia is more frequent urination during the night. Obstructive symptoms include reduce in urinary stream, intermittent voiding, and also feeling of incomplete voiding. The patient might also have pain. In locally advanced or metastatic tumor, they might have flank pain due to urinary obstruction. Suprapubic pain can be due to local invasion of the bladder tumor, and they might also complain of bone pain, where there is already metastasis to the bones. Local regional complications, such as fistula formation and extension to other organs. So if there is vesicocolic fistula, where there is a fistula formed between the bladder and the colon, they may have pneumaturia. And if there is vesicovaginal fistula, then they might have incontinence. Other presentation include metastatic complications to other organs, and also constitutional symptoms such as loss of appetite and loss of weight, and also fatigue. So to diagnose bladder tumor, these are the investigations that we can do, which are baseline blood investigations, such as full blood count, renal profile, and also we can do urine cytology to look for malignant cells. Imaging studies include intravenous or CT urogram, or even ultrasound, to detect for synchronous lesions. Flexible cystoscopy or rigid cystoscopy. Keep in view for TURBT, which is transurethral resection of the bladder tumor. So this is a diagnostic, therapeutic, and also staging modality. Besides this investigation, we can do chest x-ray of CT chest and bone scan. This is to look for metastasis to the lungs or to the bones, which will be a stage 4 tumor already. For staging, this is the staging for bladder cancer. And staging can be done through CT, abdomen or pelvis, or through the transurethral resection of bladder tumor with histopathology. So there are 4 stages. The first one, TIS, is carcinoma in situ. So you can see in this picture here, it is a flat tumor. T1, it is a superficial tumor, and it involves the lamina propria. T2 can be divided into A and B. T2A is superficial involvement of the muscularis propria, up to inner half of the muscle, whereas T2B is deep involvement of the muscle, so out to the outer half of the muscle. You can see in this picture here. And T3 can be divided into A and B. So T3A is microscopic extension outside the bladder. This is seen through histopathology, whereas T3B is macroscopic extension outside the bladder, where we can see from gross appearance of the tumor. T4 can be divided into A and B. So T4A is invasion of the prostate, vagina or uterus. So prostate for males, vagina or uterus for females. T4B is if there is invasion of the tumor into the lateral pelvic walls or the abdominal wall. So this is for the tumor part in the staging. For treatment, depending on the tumor size, so it can be generally be divided groups, which are the superficial tumor versus the muscle invasive tumor, which is T2 and above. So management depends on the stage. For superficial tumor, which are those T1 lesions, the primary treatment is the transurethral resection of the bladder tumor. And intravesical therapy is also indicated in those patients who have a high risk of tumor recurrence or tumor progression. So the intravesical therapy are such as BCG, where there is 1 instillation per week for 6 weeks, or mitomycin C, single instillation within 24 hours of TURBT, and it has shown to reduce the recurrence of the tumor. So this is for superficial tumor. Moving on to the muscle invasive tumor, which is those lesions T2 or more, then the treatment will be radical cystectomy with urinary diversion. So for the radical cystectomy, it is different for males and females. For males, we do a radical cystoprostatectomy, which is removal of the bladder, removal of the prostate, and also possibly the urethra, together with the pelvic lymphadenopathy. Whereas for female, we do anterior excenteration with pelvic lymphadenectomy. So this anterior excenteration includes the removal of the bladder, remove the urethra, uterus, cervix, and also the anterior vaginal wall. For urinary diversion, the ways to divert the urine output will be cutaneous ureterostomy, where we use ureter to create a stoma, or we can do an ileal conduit, where a segment of the ileum with ureters attached. So for metastatic tumors, where there is metastasis to other organs, the treatment will include chemotherapy, such as using gemcitabine or cisplatin, and also other medications. So chemotherapy is the treatment of choice for locally advanced or metastatic bladder cancer. For prognosis of bladder tumor, for those non-invasive tumor, around 10 to 20% of the cases will progress, whereas there is a cumulative 70% of lifetime risk of the recurrence of the tumor. For muscle invasive tumor, it is more aggressive, so poorer prognosis, and if in untreated patients, the mortality rate within 2 years would be more than 90%, which is very high if they are untreated. If they are treated with cystectomy, where there is removal of the bladder and possibly other structures, the survival rate, 5 years survival rate, is more than 50%. So that's all for this video. Thank you.